Hi there once again, and I am Dr. Abhijit Dam, and in this particular module we will be discussing about delirium. Now, delirium, it is a sign rather which you will encounter quite frequently in palliative care, especially when the patient is approaching their last days of life. Now, if you coming to the definition, it is an etiologically non-specific. So, it is a non-specific thing, it is a global cerebral dysfunction. So, it is a non-specific. So, by non-specific, that it can be caused by so many factors, like for in the elderly, if you just take an elderly, shift him from your from his place of residence, from his house, you take him and admit him in a hospital for a day, he might go into delirium because of the unfamiliar surroundings, the new faces which he sees. So, there is suddenly something new. So, his brain circuits which are now aging and degenerating cannot rapidly adjust to the new things. So, he goes into a state of delirium. So, it is non-specific. Global, that means the whole of the brain, the whole, it is not limited to one particular part of the brain, the whole of the brain is involved. So, it is a global cerebral dysfunction associated with changes in that is the level of consciousness. So, delirium is always associated with a change in the level of consciousness. The patient can become sort of sedated, drowsy, or the patient can become very aggressive, very agitated. So, both the things can occur, either the patient can become drowsy, sedated, or he can become very agitated, or it could be a mixture of these two. So, changes in level of consciousness, changes in attention, he might be sitting and mumbling away to himself, or he might not recognize the people whom he used to recognize. Changes in thinking, he might be thinking that where am I, and he might be thinking that it is night when it is actually day. He might forget that he has just had his meals. Changes in perception, memory, psychomotor behavior, emotion, and in the sleep wake cycle, this is very important. That is, these type of patients, they have changes in the sleep wake cycle. That means, they will stay awake the whole night, and the whole day they will go off to sleep, right. So, it is a hell, it is a living hell for the caregivers, because for the patient, so he is in the state of delirium, he is not exactly comprehending what actually is happening all around him. But for the caregivers, for the people who are taking care of him, changes in the sleep wake cycle can be devastating, right. So, this is an elderly gentleman, usually it happens to the elderly, those who have dementia and so on and so forth. This elderly gentleman, one of our patients, he was in a state of delirium, and then later we found out that he actually was developing pneumonia. So, infection is one of the precipitating causes of delirium. So, especially in the elderly, suddenly if you see that they are not responding, they are talking rubbish, they are not recognizing people, they are confused. So, immediately look out for infections, especially in the elderly, right. The DSM, that is the Diagnostic and Statistical Manual, DSM 4 criteria defines it with certain criteria like change in consciousness with reduced ability to focus, sustain or shift attention, changes in cognition like memory, orientation, change in language, which is not dementia. You have to differentiate delirium from dementia, we will come to that. It is always abrupt in onset with fluctuation. So, now he is okay, 1 hour later he might be totally confused, and 2 hours later he again might be okay. So, fluctuating course and evidence of a medical condition judged to be etiologically related to disturbance, like I said, especially for the elderly, you got to look out for infections like chest infections or urinary tract infections or electrolyte imbalances and so on and so forth. Severe pain can cause delirium. So, it is acute or subacute in onset, that is onset would have happened just for a few before a few hours or a few days at the maximum. Variable sensorium, so variable course, psychomotor abnormalities, there could be agitation, somnolence, as I said, they could be agitated or they could be drowsy or they could have a mixture of these. Hallucinations or delusions, they might be saying ki देखो ना वहाँ कौन बैठा है, that sort of things, you know, they might say देखो कोई somebody is coming to beat me, मेरे को कोई मारने के लिए आ रहा है, that sort of thing. So, delusion can happen that way. So, the delirium, different types of delirium are hypoactive, where the patient is in confusion, sleeping most of the time, a reduced level of alertness, or hyperactive, where the patient becomes agitated, he might be seeing things, he might be seeing snakes and scorpions and tigers, hallucinations, right, or aggression, or mixed. Mixed is most common. The mixed type of delirium is most common in clinical practice. So, prevalence, various studies have given various incidences of prevalence, but we all know that as you approach death, the incidence of delirium keeps on increasing. Various studies have using various scales for assessing delirium. There are various scales which can be used for assessing delirium, like the MDAS is the Memorial Delirium Assessment Scale, and similarly there are so many other scales for assessing delirium. Here in this particular study, they found terminal delirium in 88% of the patients, 88%, it is a huge number, right. Now, you need to differentiate delirium from dementia. Delirium usually has an abrupt onset, a fluctuating course, and then usually most of the time it is reversible, whereas dementia, it has got a gradual onset and it is progressive over period of years, and it is not fluctuating usually. Of course, sometimes the special type of dementia called the Lewy body type of dementia, those can be fluctuating, and most important is changes in sleep wake cycle are very marked in delirium, whereas changes in sleep wake cycle are minimal in dementia, and delirium is usually reversible, whereas dementia is progressive, irreversible and terminal. So, you have various scales called, the one is the delirium rating scale, one is the mini mental scale examination, right. So, various types of scales are there which evaluate delirium based on many criteria like temporal onset, perceptual changes, hallucinations, so on and so forth. Now, what could be the causes of delirium in palliative care? So, a tumor, a malignancy per se, or the metastatic, especially when if there is a metastasis to the brain and all, that can cause most of the chemotherapeutic drugs which causes electrolyte imbalances, like especially hyponatremia, hypercalcemia, these can cause delirium, right. Hyper or hypoglycemia, hypoxia, hypercarbia, renal failure, right. Infections, I said infection is a big important cause, right. Drugs like opioids, antiemetics, sedatives, all these. So, delirium could have so many causes. What is important is to recognize, is to diagnose delirium, is to recognize the entity of delirium and bring it to the attention of the concerned people. So, these are certain drugs which can cause delirium, and out of which steroids are important, phenothiazines, benzodiazepines, antiviral drugs can cause delirium, right. There is a special term called opioid induced neurotoxicity. So, this is a neuropsychiatric syndrome which happens when we keep on giving morphine for a long time, and it is a cognitive dysfunction. There is delirium, there are hallucinations, there could be myoclonus and seizures, convulsions basically. There could actually be hyperalgesia. Morphine normally reduces pain, but when there is opioid induced neurotoxicity, then you will actually get hyperalgesia. That means, there is an exaggerated pain to a painful response. or allodynia. Allodynia means where a non-painful stimulus is also perceived as painful. So, there are so many risk factors for developing delirium like high opioid doses, prolonged therapy, borderline cognition disturbances, dehydration, renal failure, advanced age. As I told you, elderly and precipitating factors, out of which infection is the most important and reversible factor. So, how do you manage? The first is to assess. First you have to come to a diagnosis. So, for diagnosis you need a high index of suspicion. And then you need to have some screening tools. You can use so many screening tools I told you about, mini mental scale examination and memorial delirium assessment scale and so on and so forth. Ask specifically about hallucinations or delusions, right. Look for a cause, talk to the family members, they will tell you कि ये कल तक ठीक थे और अभी उल्टा सीधा बोल रहे हैं. So, now he is talking rubbish, till yesterday he was fine. So, these are the clues, talk to the family members, because you are not staying with the patient continuously. So, talk to the caregivers, talk to the family members, and they will help you. So, appropriate investigations, and so this is first step is assessment, second is treat underlying cause. If there is a reversible cause like infections or fluctuations in blood glucose or sodium levels, you can treat it and delirium will be cured by itself. But what is also important is the nursing management of such patients. You need a structured settings, like as I told you, if you take an elderly man and take him to a new setting like a new hospital or a new place, he can go into delirium because it is something new for him. So, nursing such patients should ideally be done in a small dark room where there is less noise, right, and you should keep things like a clock or a newspaper or a calendar showing the current date and time, so that he is oriented with in time and place. Okay. Family support is very important. So, presence of faces which the person recognizes, otherwise if you see faces which you have never seen before, delirium can be aggravated. And then you have so many medications, out of which haloperidol is very commonly used, although the drug has recently come under a lot of scanner, but haloperidol continues to be used, and I personally use it in my clinical practice after treating any reversible causes of delirium. Like if there is an infection in an elderly, you treat the infection and simultaneously you can add small doses of haloperidol. I usually start with 0.25 to 0.5 milligram, and I give it twice or thrice in a day, and within a couple of days the patient reverts back, right. So, there are so many protocols by which you can do it, but the best is go in a stepwise fashion. You can add trimiprazine, or which is not available in India. You can use you can add midazolam. Second line drugs like risperidone and olanzapine also can be used. I have never had to use those things thankfully till date. So, as I said, the most important thing is make the staff, also the staff of the hospital, they also should be aware that this is delirium. Delirium can present like this, and make the family members also aware of the entity called delirium. Structured settings, that is, as I said, a quiet room, slightly dark room with a large clock, with a calendar showing the date and time, right, that sort of thing. Known phases all around. Minimize the use of medications as far as possible, opioid rotation if necessary, and good hydration should be maintained. So, so you need to confirm the diagnosis, look for reversible causes and interventions, and most important is nursing in structured settings, and thank you.